integrating HIV and sexual and reproductive health. I just see a thing coming up that we are being recorded. It's important for everybody to know that this meeting is going to be recorded so that we can actually sort of keep it for people who were not able to join today. If there's anybody who has a problem with this being recorded, then either you can stop your video that we don't see your face, and then you will be unrecognizable. But I'll just continue with the welcome. My name is Paul Janssen. I'm the chair of ShareNet Netherlands board, and I'm also a member of the community of practice, Linking HIV and SRHR. And before we go into an exercise to introduce who is in the room, let me just give you a little bit of a history about this meeting, because this meeting has been in the planning for more than a year. Actually, it has been in the planning since the AIDS conference in Amsterdam, where I bumped into Annette Verster, who you will be meeting later today, who was telling me that she was actually doing a piece of research at the WHO looking at contraceptive preferences of sex workers and at that time also female drug users, and which was supported by the Dutch Ministry of Foreign Affairs. So I said to Annette, well, that is a very interesting piece of work, and would you be interested to talk about this research at ShareNet? And then Annette said, I don't know what ShareNet is. So I told her that ShareNet is actually a knowledge platform in the Netherlands of people working in HIV and SRHR, also funded by the Ministry of Foreign Affairs, and it will be an excellent platform to actually talk about these kinds of topics. As it happened, Annette was planning to come to Aidsfonds, to Nienke Westerhof, and we were thinking about doing this like very small scale and just have a sort of like have a small group talking about that research. The plan became to make this a little bit bigger and do it properly. And organize an expert meeting around it, and that is what we're going to do today. We had to postpone it a little bit because Nienke had to go, was able to go on maternity leave, which is quite interesting, talking about family planning options for women. But anyway, since the 1st of December, Nienke is back, and so this is an excellent opportunity to do it today. I'm very curious to see who is in the audience, although I know a bunch of people, you may not know each other. So we're actually going to use Mentimeter to get a bit of a feel for who you are and what your interests are. Hannah is going to put up the Mentimeter. This might be a little bit of a challenge because I prepared the Mentimeter and we had a problem sharing it from one computer to the next. But Hannah, I'm going to leave it to you. Is it possible to do it?
Sure. So Paul, we're gonna just run 2 icebreaker questions with you. If you click on the link shared in the chat, you should be able to open it on your browser, or you just go to menti.com and there you will have to enter a voting code, which I'm also gonna put up here.
For those of you who've never done Mentimeter, you just go to your smartphone and you, on your Safari, you're putting menti.com. And the code is?
Yeah, you can go to the chat and just open the hyperlink there, or you go to www.menti.com and enter the code 1288802. And I see one person has already found their way into it. And then your responses will pop up here, and Paul will have a nice overview of what's your personal SRHR background.
Okay, so this is going slightly different than I had anticipated. The idea was actually to find out whether you were working mainly in SRHR, mainly in HIV, or in something else. But now we're just going to get the text boxes. So but this is fine. I see that there's only there's more coming up. So this is what we are working on: development cooperation more broadly, the WHO, HIV, both HIV and SRHR, sex workers, harm reduction, access to commodities. That's great. It's a good perspective. Youth key populations, great. And let's just give it a couple more seconds. Working at Aidsfonds, working at both, people who use drugs, working on sex workers' rights. Excellent. 12 people answered. So I guess that the rest of the people didn't know how to make it work. But that's fine. So in any case, it's nice to see that there is actually people in the room who are working on all kinds of things. And oh, that's the next question. Let me just do it myself. So if we were not working in HIV or SRHR, we would be working on a white beach or in interior design, or be a tree surgeon, or be a sailor or a designer. Well, that's great. Oh, probably interior designer. And there's another person coming on the beach. But harm reduction actually gets the most traction, because that's the biggest word. So that's nice. So a lot of people will want to have a dream profession in harm reduction, or being a translator, or be the executive director of the WHO, really? Or own a mountain hut. Anyways, let's move on. It's nice that we know who is in the room. I just want to say a couple words about the purpose of today. What we are really trying to do today at this expert meeting is for us as ShareNet members and other people who are interested to get more insight, more knowledge, hear the latest evidence, hear the latest experience about this very important topic of integrating HIV and SRHR services. And we really have been using the research that WHO has been doing as a starting point for that. What we want to know from our colleagues at the WHO is what the latest evidence is in general, what the latest guidance is in general. We want to specifically hear what has been coming out of this research. And we thought it would be very interesting, if this is the global perspective, to also get some field perspective. So we're really happy that colleagues from Mainline and Aidsfonds are actually willing to talk about how integration and linking is actually happening at grassroots level. Then we will be breaking up in two breakout groups for a very short period, to reflect on what we've been hearing in terms of new ideas and see how we can actually apply that to our own work. And after that brainstorm, we will wrap up, and we are very happy that Marja Esveld from the Ministry of Foreign Affairs will be giving a couple of closing observations. And before we go into the first session, let me just very briefly also kind of like come up with the Zoom rules. This is not a Zoom webinar, but a Zoom meeting, which is really nice so that we can actually see one another and interact with one another. It's more participatory, but I do hope that you will be keeping yourself muted when you're not speaking. If you are having a question to one of the presenters, each of the presenters will have about 15 minutes in her slot. We hope that we will have some opportunity for question and answers. When you are asking a question, just put your hand up visually or use the hands up button in Zoom. Don't just butt in. And for those of you who won't be able to ask their question during the session, there is the chat function, which you can also use to ask questions specifically to the people who are presenting. And obviously you can also use the chat function to connect with people that you see on the screen and that you haven't actually seen for a long time and wish all the best or ask a question. So those are the rules for Zoom. I'll shut up here and I will just give the floor to Annette Verster, who will be setting the scene for what we're actually talking about when we're talking about HIV and sexual and reproductive health integration. Most of you probably will know Annette. Annette is currently working at the WHO as a technical officer at the HIV, STI and hepatitis department. Annette has a long history working with key populations. Annette was the first AIDS coordinator for the city of Amsterdam, and she was also one of the first people actually setting up needle and syringe exchange programs for people using drugs. Subsequently, she moved on to global work, and she's still at the WHO. And I'm really happy, Annette, that you will be giving this opening word. So the floor is yours. Annette, you have to unmute yourself.
Yes, I'm sorry, I had some internet problems. All of a sudden it's all stopped. So I didn't hear what you said, Paul, but I'm sure it was brilliant. So thanks very much. I just wanted to say that I'm really happy that we have this event, and I would really like to thank Paul particularly for organizing this. And if you don't mind, I would like to make a little personal note here. As some of you may know, I started working in the field of HIV in the 1980s, late 80s, at the start of the epidemic, very different time. I worked after working in methadone clinics in Amsterdam, I joined the Department of Public Health of the GGD to become the first AIDS coordinator for Amsterdam in 1986. And it is a job that has helped define me as a professional and as a person. The aim of my position, and it's actually quite interesting, was to normalize and integrate HIV in mainstream health. So I think in a way very much along the topic of today, and basically I had to make myself redundant. That was the objective of my job. And so it was a really important part of my job was to work with people from various key population groups. And there was a strong link with sexual and reproductive health at the time, whether it was the STI clinic for sex workers or family planning, etc. So after leaving my job in Amsterdam in 1994, I've done a few other things, and here we are. So we're in a meeting with key partners in the Netherlands on HIV and sexual reproductive health and rights. And so I'm getting this sense of rounding a circle, if you understand what I mean. Overall, there's definitely growing recognition that HIV and SRHR should be and are getting more integrated. And of course, ShareNet is a leading example of this. WHO as well has taken the step to integrate the global programs of HIV, viral hepatitis, and STIs into one department. So it's not, reproductive health is not really part of the department, but there's very strong links, and this will be discussed later on. So for example, we're updating new key population guidelines, and these will be looking into HIV and hepatitis, STIs, and sexual health more broadly. So, but at the same time, I have the feeling that HIV still leads the polls, and many colleagues in HIV would in the HIV world seem to find it difficult to consider the links with other sexual health conditions. And there may be reasons for this, but the fact is that this meeting is highlighting this, and that the Netherlands, I would say again, is an important leader in this area. Integration is a key concept, whether it's in the context of universal health coverage, person-centered care. Integration is about service delivery, one-stop shop, as well as decentralization. And we also talking about task shifting, but a little bit less today. So the focus today is predominantly on integration. It's of course so much common sense that when you reach a person for, say, HIV, that you have to assess other related STIs or drug use or reproductive health, because you're meeting this person. So it just makes sense in terms of efficiency, in terms of human rights, and especially where we're talking about people who are marginalized or stigmatized. Once you reach them, it is really important to make sure that people-centered care and a range of related issues are dealt with at the same time. So without taking much more time and reminiscing about the history, I'm really delighted to present two of my colleagues, as well as, I don't know who's going to present because I might have missed that, colleagues from Aidsfonds and Mainline, but of course we're working closely with Aidsfonds and Mainline as well. But my colleagues in WHO will demonstrate and present how the efforts and how HIV and SRHR are coming together. Do you want me to introduce the first, or is someone else doing this?
I think you're doing a marvelous job. Just go ahead. Introduce
Okay.
and I will introduce Virginia later.
Okay, so I'll introduce my dear colleague, Michelle Rodolph, who I've worked with for a long time, first on key populations, and now she leads the work on PrEP in the department and also on linkage with reproductive health. And she will present overall WHO guidance that's most relevant to the topics today. Michelle is the technical lead on, okay, I've said that, on PrEP and on integration between HIV and reproductive health. Michelle.
Thanks, Annette. I think someone's going to share my slides. So I want to say this is a real privilege to me to be introduced by Annette. Annette was my first supervisor when I came to WHO far too long ago. So thank you, Annette. And thank you, Paul, and the rest of you at ShareNet for inviting me to speak. I assume, is it Hannah who'll be moving my slides? Oh, no, just go back to the front. The first slide, please. Okay, so Hannah, just so you know, we're going to skip that second slide because that was left in by mistake. So I will be timing myself. My goal is to speak for about 10 minutes. So if you hear a dog barking in the background, that is my timer. And I want to speak for 10 minutes to allow some time for questions. I have around 20 slides, which I plan to move through quickly, not to take away from the depth of what's inside the slides, but so that when the slides are shared with you, you'll have as much detail as possible. So I'm entitling my slide, Taking ECHO Forward, New Guidance from WHO on Contraceptive Services. And what I want to do is give a little bit of background. Can you go forward 2 slides? Okay, perfect, thanks. So why ECHO? Let's go to the next slide, please. And I guess you have to move through the apologies. Oh, go back, thank you. So why ECHO? ECHO is a trial that was designed a number of years ago and finished a year and a half ago. And what it was designed for was to look at unresolved questions. There's been, for over 30 years, there's been an unresolved question that do the hormones and different contraceptives provided to women increase a woman's risk of HIV acquisition? Can we go to the next slide, please? So ECHO was designed to answer that question. ECHO was designed, the trial design, which was how it was implemented. ECHO recruited 7,800 women ages 16 to 35 who wanted to prevent HIV, to prevent pregnancy. The design of ECHO was set up to see, does DMPA, the implant, or copper IUD, do any of these methods increase the risk of HIV acquisition? The study was implemented at sites in South Africa, Eswatini, formerly known as Swaziland, Zambia, and Kenya. And these sites were chosen because they had higher rates of HIV prevalence in the population of women. And the idea was that by implementing the study in these sites, we would, and by randomly assigning contraceptive methods, we would be able to answer the question of, does any of these methods increase the risk of HIV acquisition? Next slide. Can you continue the animation? Apologies. I think there's one more. Thank you. So what the trial showed us was, if you look at the box below and in bold, the trial did not find a substantial difference in HIV risk among the methods evaluated. It also found that all methods were safe and highly effective for pregnancy prevention. Now, this trial was important for WHO guidance because, as you'll see later in my presentation, WHO has guidance on what contraceptive methods we recommend for women depending on their situation. For example, increased risk of HIV infection. What ECHO did find was let's look at the top box in the right. What ECHO did find was an unacceptably high incidence among women across all different contraceptive methods. So you'll see 4% incidence in the DMPA injectable, almost 4% in the copper IUD, and just over 3% in the implant. Now, this high incidence is not attributed to the method of contraception, but what it is attributed to is that the women, although they reported low risk, are living in areas where they are at an increased risk of HIV and therefore need HIV prevention. Next slide, please. So as you can see here, it's a summary of the HIV incidence across the sites instead of by method. So seeing this high HIV incidence and the high STIs, it was critical to WHO that we work with our colleagues in sexual reproductive health. And we also, and with our colleagues in HIV as well, to overcome barriers in family planning clinics to discuss HIV and offer HIV prevention. Next slide. So let's continue on. Next slide. Okay. Go back. Thanks. So moving backwards a little bit here from the work, because what I want to show those of you in the audience is that this is an example of the medical eligibility criteria for contraceptive use. It comes out regularly, and after we had the results of the ECHO trial, we updated this. Can you move forward to the next slide? Thank you. So let me go back a little bit here, stay on the same slide. But what the MEC, as we call it, does is it goes through the different contraceptive methods and it gives them a number, a value. For example, a condition for which there's no restriction in the use of method, that would be a 1. A condition where the advantage outweighs theoretical proven risks would be a 2, and you can read as we go down. I want to draw your attention to the 2. Before the ECHO study came out, DMPA went up and down from a 1 and a 2 within WHO because we didn't know. We didn't have any absolute proof if DMPA increased women's risk or not. So before the ECHO trial, it had just gone back to a 2, where we believe the advantages of using DMPA outweighed the risks. Can we go to the next slide, please? Let's go to the next slide, please. Okay, so you'll see here, this is the current recommendation for DMPA for progesterone-only contraceptives. So after the results of ECHO, the MEC was revised for DMPA to be a 1. And this is how, based on the available evidence, we see it standing, that we do not see DMPA increasing women's risk of HIV acquisition. This is very important in a number of countries we work in because DMPA is the most, especially in sub-Saharan Africa, DMPA is the most commonly used method of contraception. So one fear with ECHO was that if ECHO showed that DMPA increased women's risk of HIV, that women may lose their primary source of family planning. So on to the next slide. Next slide, thanks. And just you can go again one more time. Thanks. Go back. I apologize for this. I apologize. Another thing that came out of ECHO is we saw that the IUD, but we saw the copper IUD was looked at in the ECHO trial, although we have no reason to believe that the levonorgestrel IUD wouldn't be different. Both forms of contraception used to be a 2, meaning we believed that the benefits outweighed the risk, but we had no absolute proof. After ECHO, we saw that there was no difference in HIV acquisition for any of the methods. Therefore, previously, the copper IUD and levonorgestrel IUD used to be 2s. After the results of ECHO, they were revised to a 1. And what this means is that there's no restrictions on women at risk of HIV using any of these contraceptive methods. Next slide, please. Thank you. So the implications for policy, programs, and providers. A woman's risk should not restrict her contraceptive choice. Now, I believe this, in my conversations with Paul, we discussed at this meeting, some of the participants work with sex workers, some work with women who use drugs. I saw in the chat some introductions. And my experience is women in sub-Saharan Africa who don't always list or state or report if their risk is about transactional sex or is linked to drug use. Many of the women live in areas where the baseline prevalence is high, and that is their main risk. Although this is applicable to some of those of you in the audience, given that you do work with women or represent women who are at higher risk. And I guess I'm thinking of a way to say it. It's not my message is, but what you could take from this talk is that WHO's message is that we don't foresee, depending on a woman's risk of HIV, there is no reason to restrict her contraceptive choices. Can we move on, please? Next slide. So the conclusion, after the ECHO trial, WHO updated their eligibility criteria for women in high risk. And we removed all restrictions on contraceptive method for hormonal contraceptions. Next slide. I'm just checking my time here. Oh, I'm going slower than I thought. So post-ECHO refocus needed. What we learned from ECHO is that we need to do more work in making HIV prevention services accessible to women seeking contraceptive services. And we need to expand the locations where women can receive their HIV prevention services. Next slide. So this document that Paul may have shared in the information pack, if not, I can show the link, is something WHO came out with earlier this year, where we've started putting together an action plan for how family planning services can address HIV and STI prevention needs. Next slide. This goes through a focused approach. Next slide. And we talk about other prevention choices. Now, oral PrEP has been rolled out in sub-Saharan Africa, but it's not only about PrEP. Rolled out in sub-Saharan Africa among women. My understanding is in the West, speaking North America, where I'm from, in Europe, it's not as available among women. It's more geared towards MSM. But it's not only about PrEP. It's also about male and female condoms and involving partners. And looking to the future, the dapivirine vaginal ring was just approved by the European Medicine Agency for use in low and middle income countries. We have other future products that are coming out. For example, a long-acting cabotegravir injection. Next. And this is my last slide. But as last but not least, we also at WHO are looking at not just working on HIV prevention and family planning services, but looking at and advocating for quality contraceptive services for women living with HIV. Women living with HIV, there are unmet needs for contraception. There are unmet needs for fertility, and these also should be addressed in HIV treatment programs. And just my last slide, next slide, is just to thank my wonderful colleagues and Paul and those of you at ShareNet who made this presentation possible. Thank you.
That's wonderful. Thank you so much, Michelle. And you did so well on time. So we do have space for a couple of questions. Can I see a hand? I don't see a hand, but maybe Hannah sees a hand.
It's hard to find the hand on Zoom, I found.
People can raise a hand. I don't see any hands raised. Okay, that's fine. Then maybe we will have questions later. That's fine. Then we run in on a little bit of time that we lost, and I will give the floor to Annette again to introduce her other colleague, Virginia. Annette, the floor is yours.
Thanks, Paul. My other colleague is Virginia Macdonald, and she leads with me the work in WHO on key populations and infectious diseases. And she really has helped to bring the work on this area within the department and the organization to another level. So I would like to take the opportunity here also to thank again the Ministry of Foreign Affairs, Buitenlandse Zaken, of the Netherlands for supporting us, our department, in 2019 to scale up our work on key populations around the world, and to work towards improving integration of HIV and SRHR, because this was really one of the requests or one of the conditions that we would do this in order to receive the contribution. So again, one of the many initiatives under the Dutch brand is a survey of the values and preferences of contraceptives among sex workers. And I think I can leave it here directly to Virginia to explain the details on that. But it links to the background that Michelle has just given as well. Thanks.
Okay, thank you very much. It's nice to be here, and thanks for inviting me and for a nice introduction, Annette. So I am presenting results of a values and preferences study that we conducted amongst sex workers. The work was conducted with staff at WHO, but also the lead author for this work, actually, I should acknowledge, is Euphemia Sibanda, who works at the Center for Sexual Health HIV AIDS Research in Zimbabwe, SESHA, if people have heard of SESHA, and they have an outreach program called Sisters with a Voice. And the other consultant that worked on this with us was Anya Shapiro. So just to acknowledge the two of them for the work they did on this. Okay, thanks. Next slide. To give a bit of background, on the right here, we have an estimate from UNAIDS that shows global distribution of new infections. The current estimate for 2019, they redo this estimate every year, and the proportion of new infections that are attributable to key populations increases year on year because we're not really improving the coverage of services for key populations at a high enough rate. In this one particularly, I draw your attention to that 8% of new infections globally occur amongst sex workers. And also if you go down, you see there's another 19% of infections amongst the clients of sex workers and other sex partners of key populations. And this donut changes by region. So in regions like the Western Pacific and Southeast Asia, in the Eastern Mediterranean, the proportion of infections occurring amongst key populations is much larger than this figure here. And then on the left, it's just showing some results from a pooled prevalence study conducted in various African countries. And I've put a little red box around this plot showing results for higher risk women, and these were mainly sex workers in this study, just to show the increased prevalence of gonorrhea in this group. It's we see the similar results for chlamydia and syphilis. I haven't shown them here, but if you want to go to this paper, you can have a look and see all the results there. Next slide, please. And really important, of course, and what makes sex workers different from many women who would be trying to access HIV and or family planning services is the fact that in almost every setting in the world, some aspect of sex work is criminalized. This criminalization makes sex workers more vulnerable to arrest, incarceration, and police violence. It also increases stigma and discrimination against sex workers. And the forest plot here I'm showing is a really amazing piece of work, which I would encourage you to look up, showing really quite strongly the direct impact of these structural barriers on HIV and STI infection in sex workers, including arrest, sexual physical violence, and incarceration. Next slide, please. And sex workers have also unmet family planning needs. There's not a whole lot of research on this, but just showing here in a study of incidents of sex workers reporting unintended pregnancy. And you can see in various studies, it's quite high, up to 60% in a 2009 study. And single country papers show, unmet need for contraception, around 64% in Kenya, 35% in Madagascar and in China. Okay, next slide, please. So the reason we conducted this study is very much linked to what Michelle was talking about, because when WHO makes a recommendation and holds a guidelines development group, as they did for the MEC, which Michelle mentioned, which was about contraceptive choices for women at high risk of HIV. Anytime WHO conducts a guidelines development group, they look at the evidence from peer-reviewed journals, but they also want to look at the values and preferences of communities and end users. And so we worked with our partners in RHR, who are responsible for the update of the MEC, to look at sex workers' values and preferences related to contraceptives, and took the results of this study to the guidelines development group meeting for their consideration while they made recommendations. And I think it was the first time that sex workers' values and preferences had been included in the MEC recommendations guideline development group. And so that was a really great first step, which is quite surprising. But I guess we kind of had an in, because this one was specifically about women at high risk of HIV. So it was clear that, that sex workers were an important group. So it was a mixed method study. We conducted in-depth interviews over the phone with no country restriction, an online survey which was available in 3 languages, and also focus group discussions with sex workers in Zimbabwe. And this was all the questions and focus group guides were based around a framework to look at sex workers' values and preferences for contraception. So it was not designed to look at integration of HIV and family planning, more specifically about contraceptive use and influences on contraceptive decision making. Okay, next slide, please. So we had a good result from our online survey, 239 participants from all 6 WHO regions. And we had to make some effort and outreach to ensure that we had 107 participants from lower and middle income countries. And it was very helpful that we were able to translate this survey into both French and Russian, meaning that we had better representation from West Africa and from Eastern Europe. There was 12 in-depth phone interviews conducted, and in Zimbabwe, focus group discussions were with 56 sex workers and key informants, and we had an average age for all around 30. So, okay, thanks. So we found that overall sex workers in Zimbabwe and also in our online survey had a pretty good knowledge about different contraceptive methods. We looked at differences on the online survey between those that came from high income countries and those that came from lower and middle income countries. And it did seem that people in high income countries were aware of a greater number of contraceptive methods. Particularly knowing 76% of women in high income countries had heard of hormonal contraceptive patches versus only about 32% in low income countries. Contraceptive rings and diaphragms are also known quite widely in high income countries, but not so much in low income countries. But overall, there was good knowledge. However, the focus group discussions, when we were able to really look at that knowledge and where the gaps might be, revealed quite some misinformation. And here is a quote from a woman not attending the Sisters with a Voice program, but sex working in Zimbabwe. And she's basically saying that if she drinks bicarbonate of soda mixed with water, then so will explode the sperms and they will fall out of her. Next slide. Again, these are more results from the online survey here in the chart. And this was questions about which contraceptives women had used in the last 1 year. And you can see male condoms were most frequently used. But while 85% of sex workers always use condoms with their clients, only 26% were also using condoms with other partners. The parts of the chart that I have put the little star next to is those results which were statistically significant, comparing high income countries in blue and low income in the sort of grayish color. And you can see that injectables were more frequently used in lower middle income countries, whereas IUDs were more frequently used in high income countries. And I've just put circles around these two parts of the chart showing that in both high income and low income countries, around 20% of women reported using emergency contraceptives in the last 1 year, and slightly less than 20% had used traditional contraceptive methods in the last 1 year, pointing to unmet contraceptive need in both these settings. And also, yeah, participants in the focus group said that, you know, condom use with clients, condomless sex with clients was also common, and sometimes they were coerced into not using a condom when they had sex with male clients. Next slide, please. Okay, this may be a little bit hard to read, but it's talking about those attributes which were more valued by sex workers, contraceptive attributes. And you can see in each of these charts, it compares lower middle income countries and high income countries. And when there's more dark brown, it means that that attribute was more important to that group. So the importance of it is graduated with the color. And I think, you know, the sort of striking findings for me were in lower middle income countries, where it was very important that contraceptive methods were discreet and that the client did not know that women were using contraceptive methods. And this quote from one of the in-depth interview participants from a lower and middle income country in Africa is just giving a little bit more color to that, saying that the one advantage for the coil is that you can't easily get pregnant and it's inside, so the client won't be able to tell that you have the coil. And also in lower and middle income countries, they placed more value on contraceptives which were recommended by personal acquaintances. than women in high-income countries. Thank you. Next. We asked some questions about what the influence of other people on contraceptive decision-making was. In lower and middle-income countries, clients were more likely to value the opinions or be more influenced by the opinions of male partners, be them clients or their regular male partners. And here's just a couple of quotes to show. We have the top quote from a woman in Zimbabwe saying that, you know, her client is saying that if she uses Jadel, then she's not delicious, and that he won't enjoy having sex with her. Whereas a woman in Australia, the first thing she says is when it comes to clients, it's just not negotiable. So we just see a bit of a difference in those two settings again. Next slide, please. We're really interested to see in Zimbabwe that the results showed a lot of coerced childbearing, and that actually a lot of the male clients wanted to have unprotected sex because they had a desire to have a child with the sex worker. And the quote on the bottom saying they can take your pills and boil them, and by the time you take your pills, they have no power, and then you find yourself pregnant because they want children, not the woman, but the client. Next slide, please. We also asked about what were the barriers to accessing family planning services, and while many women had said that they were going to healthcare facilities to access family planning, that healthcare providers sometimes had poor attitudes towards them, and they just experienced stigma and discrimination, which was a considerable barrier. There was also barriers related to cost and drug stockouts. And this quote, yeah, that sometimes in public services, it's hard to get contraceptives because they take you as someone who is sinful. They can't receive you well being a sex worker. And they say, if you don't have a husband, why would you be needing contraceptives? Next slide, please. So there's actually, this is a very short summary. There's a lot of data from the online survey in particular, and we're really hoping to publish this soon, and we will, you know, I'm happy to send copies of that when it's available. So in summary, we saw that while knowledge was good, there's still gaps, and there's a lot of myths around contraceptives that exist. Women in lower and middle income countries placed greater value on the preferences and influences of their clients and spouses. The contraceptive preferences really depended on the setting, and judgmental attitudes from healthcare workers created a barrier to sex workers accessing contraceptives. Next and final slide. So in our guidelines for key populations, we recommend and continue to recommend how important it is to address structural barriers for key populations when they're trying to access services. And this includes reducing stigma and discrimination in healthcare settings, also decriminalizing sex work, and improving law enforcement responses to sex workers and reducing stigma and discrimination in that group as well. It's clear that women had a very wide range of contraceptive methods that they used and wanted to use, and various different attributes that they valued, meaning that we need to ensure that those contraceptive methods are available to them. Obviously, there's myths, there's knowledge and understanding that needs to be increased in sex workers, but also in their clients who are perpetuating, and sometimes actually the ones that are feeding them this misknowledge. So men, their male partners and their clients need to be involved as well. And of course, the other structural intervention that we recommend in our guidelines is community empowerment for sex workers to support their contraceptive decision-making. Thank you.
That's great, Virginia. Thank you so much. I'm just opening the floor. I'll just see if I see hands coming up, or yes, Muna has a question. Muna, go ahead.
Thank you, Virginia. Thank you. Thanks a lot. I think a lot of your results and the recommendations are very common also in our world field. What I was wondering is, what we note in the field is that a lot of the women who use drugs also engage in sex work. in order to provide for their drug use, or the other way around, for the women to engage in sex work, they use drugs to keep up and cope with all the stress that comes along with. So what I wanted to understand is why does this research haven't considered the needs of the women who use drugs, especially knowing that drug use has a different dynamic to a body, a woman's reproductive and health system. So I'm wondering why haven't that been included, and if there will be a follow-up to include that part in order to have a wide range of all the recommendations that you now provided for the sex work community to also adapt to the women who use drugs. Thank you.
Should I respond now? Yeah, thank you. It's a really excellent point, because of course there are women that inject drugs, there are female prisoners, a lot of our key populations, transgender men, you know, there's a lot of other key populations apart from sex workers for who these questions are relevant. To be honest, it was a matter of time and funding that we decided to focus on sex workers this time round. And yeah, I mean, I think it's a great idea to keep doing this, and particularly to look at women who use and inject drugs. I agree, it's a good idea.
Great, thank you, Muna, for that question. Any other question? Corina, go ahead. Corina, you have to unmute yourself.
I needed to find a button for the unmute. Yeah, very interesting to hear. In Latin America, you have a lot of sex workers organizations, a kind of trade unionism, and that helps a lot with supporting, with kind of peer support. Also in, let's say, promoting access to condom use and other contraceptives and other forms of support. It was also mentioned in your study that, let's say, community empowerment is important for sex workers. I was just wondering if in the Africa study, if you have come across sex workers organizations, and if that would make if that made a difference in, let's say, the attitudes towards, let's say, condom use, knowledge, and so on. So that's my question.
In Zimbabwe, yeah, I didn't present the findings, but they did conduct focus group discussions in those women that access the Sisters with a Voice program, which is a community-based, peer-driven sex worker program. So in the Sisters with a Voice, the women that were coming to that service certainly had better knowledge and better access than the women who weren't accessing that service. So indeed, and I don't know that I showed that in the slide, but the sex workers did really value the advice and support of their peers, obviously, when it came to contraceptive decision making. So it's really important to support them to do that, and to make sure that good knowledge and information is available through those channels as well. Yeah, I think that's, you were asking about Zimbabwe, is that correct? Yeah, thanks.
Okay, great. I'm aware that there might be more questions, but I'm also aware that we're running a little bit late in our schedule. So if anybody has any more questions, either for Virginia or for Michelle, put them in the chat box, and then you will get an answer. You can actually direct them specifically at them. So this has been excellent. We've heard from our WHO colleagues, that we heard from Michelle that really there is no barrier to hormonal contraception for any woman at risk of HIV, be them sex workers, drug users, or living with HIV. And we heard from Virginia that the research showed that sex workers do have family planning needs and do actually have preferences on what they want to use. We actually saw that most of them are actually still using condoms, but they do actually value choice. And a very important thing that came up as well is that the structural barriers when it comes to family planning services or any kind of services for sex workers. So what we're going to hear now is we're going to hear from people who actually have field experience, and I have been working a long time with women at risk of HIV. And first of all, we're going to hear from Muna. Muna is working for Mainline. Mainline is the harm reduction organization in the Netherlands, but is also working internationally in the Bridging the Gap partnerships. And Muna is specifically responsible for the programs for drug users in Kenya and South Africa. Muna has a background in molecular biology, but fortunately she moved into public health, and now she's been working for a couple of years already at Mainline. And what we're going to hear is actually, we've talked about the sex workers. Now we're going to talk about women who are using drugs, and as Muna said, are often also selling sex. So let's hear how integration works for them. Muna, the floor is yours.
Thank you, Paul. Thank you very much. And yes, the molecular biology would also come in hand when we're talking about the sexual and reproductive needs of women. But that's another topic. Thank you, Hannah, for navigating for this presentation. As Paul already mentioned, my name is Muna. I work for Mainline, and I oversee the harm reduction program in Kenya and South Africa. We work, next slide, please. Through Bridging the Gaps, funded by the Dutch Ministry of Foreign Affairs, we work with local organizations in 6 countries across Southeast Asia and Eastern South Africa, where we provide harm reduction services together with our local partners alongside the WHO guidelines. But in addition, we also provide paralegal services and mental health support, both at drop-in centers and at outreach base. Hannah, can I have the next slide, please? Oh, I think I'm moving too forward. Can you go back one, please? Yes. Sorry, so by providing harm reduction services, we utilize the concept of meaningful involvement as a means of capacitating the people who use drugs, but also to make sure that the services match the needs of all PUDs, all people that use drugs, including those that are generally overlooked in mainstream harm reduction services, which are funded through HIV/AIDS programs. Fortunately, through the Dutch Ministry of Foreign Affairs, the Bridging the Gaps funding is flexible enough to also include for us to provide services for non-injecting drug use, stimulant drug use, and youth who use drugs, but also women who use drugs, which is the topic of this presentation today. Yes, so in many parts of the world, women who use drugs face severe gender, social, and economic inequalities that adversely affect their health and well-being, and thereby their basic human rights. The vulnerability of women who use drugs are multifaceted, intertwined, and too many to cover during this presentation. Therefore, I will only go into some of the most relevant, which can be categorized in 2 groups. Luckily, some of them are already mentioned in the previous presentation, and you will see a lot of overlap in that as well. As you see, the vulnerabilities mentioned here in this slide are the majority of the personal factors. Women who use drugs are more likely to be homeless, face all sorts of violence, including gender-based violence and sexual violence, engage in sex work to support their drug use, as mentioned earlier, but also the drug use itself, which all contribute to their vulnerability, including HIV and STIs, cervical cancer, unplanned pregnancies, mental health distress, and so on. Next slide, please. Sorry. In addition to the personal factors, there are institutionalized factors that contribute to the vulnerability of women who use drugs. As drug use is criminalized in almost every country in the world and generally considered as a masculine behavior, women who use drugs face stigma, discrimination, incarceration, isolation, and basically shunned from the rest of the world. If the personal factors mentioned in the previous slide are also relevant, so being homeless, women who use drugs being homeless, women who use drugs being a sex worker, or maybe HIV positive, they face double, if not the triple stigma compared to their male counterparts. All these factors cause these women to go into hiding, especially if they have kids, because all the above could mark them unfit for parenting, and therefore they might lose the custody of their children. And then we have the fact that despite being a priority population for HIV prevention and harm reduction programs, the gender-specific needs of women who use drugs being largely overlooked, because these women are not accessing services due to the aforementioned barriers, but also in addition to the service providers' attitude. I think that's also mentioned in the research. But also the service providers not knowing what these women actually need, which is largely linked to their lifestyle and behavior. I think you can all agree with me that this is disturbing, especially knowing that women who use drugs make up close to, if not more than 20% of the total global estimate of people who inject drugs, of which the majority is of reproductive age. So you can imagine. However, these numbers do not include the women who smoke heroin or crystal meth or use any other substance that is not administered through injection. As I mentioned before, injection drug use is largely the target population for when it comes to HIV and AIDS programs, and therefore mainstream harm reduction programs. So these fall all out of the target population in these categories, which leads to unmet needs of women who use drugs, be it HIV, SRHR, harm reduction, general physical and mental health. As a response to that, and in line with the meaningful involvement concept, we have developed the gender-sensitive harm reduction approach together with our Kenyan partner, Mewa, who's based in Mombasa, which I will not go into detail, but if you see my slides, you'll all have, they have these links in the below of the slides, and you can find information further on the pilot projects, but also on the gender-sensitive approach itself. Next slide, please. Yes, so the gender-sensitive approach is based on creating a low threshold access to services and a safe space for women and their children, with women-only hours at the drop-in centers and female outreach workers out there for those that are not entering the services, and covering some of their basic needs such as shelter, nutrition, nutritional support, and sanitary and hygiene kits. So basic human rights stuff, just as an incentive to get them to access services. Well, in a collaboration with the local government, Mewa, our partner in Mombasa, previously provided the SRH services on referral base. But since the DIC is now licensed as a clinical service provider by the government, the services are now all provided in-house. Through the gender-sensitive approach, the increase of both SRHR and harm reduction services grew exponentially. Whereas in 2016, we had less than 20 women accessing services. Now we have 500. And this is despite COVID, which I can imagine all of the service delivery for all key paid populations have must been interrupted. Currently, over 200 women, or no, close to 200 women are accessing family and planning services, of which I think the preferred method is injection, because it's, well, easily kept up. And the second being oral contraception. Thirdly, the condoms, male condoms, I must say. Some of the barriers we see affecting use of contraception in this population are pregnancy intentions. They want to conceive. In line with what the previous presenter mentioned, is because maybe their partners or their clients want so. But also because of drug use, they might miss a period or 2 or 3. And this is perceived as, I'm not getting my menses, this I cannot conceive, this I'm not going to need family planning services. So this information, lack of knowledge and information is also a gap. The reported side effects of, for example, the oral contraception is also an issue, the chest pain, the headaches, the weight gain, you name it. One of the biggest hurdle is partner influence. If the partner is not willing for the woman to access these services, it's most likely not going to happen. In addition to the complex healthcare appointments and the transportation costs involved to get these women to these services. So all that turns into play. Next slide, please. Over the past years, since 2016, when we started this pilot in Kenya, up to now, what we've learned is that we cannot stress how important it is to look at access. And when you're talking about access, not mentioning that you need to open a clinic somewhere who's fancy and has all these methods lined up out there. No, we're talking about, we need to understand first who are we dealing with? Women who use drugs, it's not a homogeneous group. We're talking about women who use drugs who are homeless. We're talking about those who might engage in sex work, transgender, HIV positive with kids, or maybe intentions to have kids soon, partner or family violence involved. All that comes into play when you want to provide access, low threshold access. Followed by, how do you want to provide these services? Again, time, location, and cost. All that is important when you're hoping to get them to access these services. And not to forget is, what kind of support do these women need? So their preferences for family planning based on their needs and also their lifestyle. A woman who uses drugs but is a sex worker would need different times of coming to service than a woman who's homeless and might not have means to come to these drop-in center, for example. So all that is important, specific needs of the woman that you're catering for, but look at specific needs within women who use drugs. And then the institutionalized barrier is deal with stigma and discrimination. Start with sensitizing health workers, both public health, but also community-based organizations. Also, these need sensitization on how to deal with women, all variety of women. As an incentive, cover their basic needs, get nutritional support for them and their children, shelter, clothing, sanitary and hygiene materials, just to get that kickstart to get them interested in the service that you're providing. The myths and the knowledge gaps exist, so create awareness in this, thereby create demand. The knowledge on HIV, AIDS, SRHR in combination with drug use, but also with pregnancies is low, not only with the PUD community, but also with health workers. And the other thing is psychosocial support is key, not only for the woman who use drugs in order to give her tools to improve her health-seeking behavior, in order to negotiate on safe sex, abortion options, and general mental health, provide her skills and insights on how to take care of her kids, in order to make informed choices for herself, for her children, for her unborn children is important. The other thing is families and partner. You need to get them involved as well in order to create that enabling environments and this create demand. Next slide, please. Way forward. We've started off in Kenya, expanded into Tanzania and South Africa, through collaboration with local government, PEPFAR, Global Fund, all the donors involved in the countries that we work in that also fund the programs that we're involved in. All that come together, provide services, provide insight, provide the capacity building for the organizations that we're supporting collaboratively, took us to levels that we understand majority of the needs. I would not say all the needs of the women who use drugs, because we're still exploring, and it would be interested to have follow-up research of the WHO include women who use drugs so that we can take this to a further scale. We luckily have the government in Kenya taking up the gender sensitive approach in order to expand it to nationwide. It's now included in the national TOT curriculum for training public health workers, but also community-based organizations on dealing with HIV and AIDS when it comes to KP, when it comes to general population. What we else could do is disseminate lessons learned. We're doing that on different platforms through different channels. You see links below in the slides as information that we disseminate, but also we take part of discussions and seminars like we're doing right now. Thank you.
Great, Muna, thank you so much. And I find it fascinating to hear a completely holistic take on integration, where you basically say that women who use drugs have not only HIV and SRHR needs, but many more needs, and how you basically explain how sort of the standard harm reduction services are essentially not meeting those needs, and how you're not just taking a sort of like a narrow HIV family planning integration angle, but really sort of like a gender sensitive angle, and that might actually be more appropriate for the women that you're working with. I'm going to skip the questions now. I'm going to ask our colleague from Aidsfonds, Anna, to take the floor, and then we'll just have like a question and answer session after the two field experiences, because Anna is providing also a very interesting perspective. We just heard about the women who use drugs. We've heard already about sex workers. Anna is going to talk about sex workers and then give a specific case study about how then to actually deliver those integrated services. And this is a case study from the Ukraine, where Anna is actually from, although she's been in Holland for a long time. Anna is working with Aidsfonds, as I said. She's working particularly on supporting sex worker-led organizations to address not only HIV, but empowerment in general. And Anna has a background in human rights. In an earlier incarnation, she worked in Brussels, working on human rights and advocacy for young people and LGBTI communities. But we're very happy to have her at Aidsfonds. And Anna, the floor is yours to talk about Ukraine.
Hi, thanks so much, Paul, for this nice introduction. And I'm very excited and honored to be here today. Also quite nervous, I have to say. It's the first time I'm attending this community and have a privilege to share some of my expertise, which, yeah, I still feel is quite narrow in comparison to what I heard from colleagues. Nevertheless, I'm really happy to share today the most recent data and the knowledge we have from our partners in Ukraine. Just to give first introduction to them, fair one, is that in Ukraine we work with the only one sex worker-led movement, self-organized sex worker-led movement, which is called Legalize Ukraine, and they work in more than 10 regions of the country, really grassroots, so providing various support to sex workers, mainly empowering them to know their rights, to be able to step up, to make their voices heard. And they work a lot on achieving decriminalization of sex work in Ukraine. It's essentially their goal. And but still, of course, they carry out lots of various work related to advancement of sex worker rights in the country. And in that framework, in the last half a year, they conducted a survey in which they asked around 100 female sex workers about their general level of satisfaction with SRH and HIV STI services in the country. Essentially, where do they get those services? What's enabling them to get the services, and what on the contrary are the barriers to access? And I wanted just also to give more of a holistic picture. So I think we started really technical, talking about contraception, and then we were zooming out a little bit, also looking at the broader needs of different communities. So it's very good. I think that my piece comes in the end, because it's just like a good continuation of the zooming out picture, but it's also simultaneously building on what Virginia mentioned earlier about the study on sex workers, and what we just heard from Muna about the specific needs of the marginalized communities. So without further ado, I'm going to dive into my presentation. I would ask Hannah to put the next slide. Thanks. So on this slide, you can see quite a division between HIV STI services and SRH services. So to easier read it, on the left column, it's basically the general overview of the places where a female sex worker could get HIV STI services, and also general list of the kind of services that are there, whereas on the right, in the right column, you would get the same overview, but more for SRH services. So it could seem quite that there is quite a division in the two, which is actually, unfortunately, the truth still in the country. And I would also walk you through the differences in both kind of services, and also mention what are the links between them. So what helps now and then to actually integrate one another. So when it comes to SRH services, they are generally provided in the public or private healthcare facilities, which are quite many, and the system is complex and quite flawless, unfortunately, since the healthcare essentially in Ukraine is free for all. And ideally accessible for all, but we all know that the economic situation of the country is still far from ideal, which also negatively reflects on the quality of the free and accessible for all healthcare, unfortunately. And that results in practice that many essential services, equipment, and very often qualified personnel is missing or is very scarce, and so the clients entering public healthcare services have to wait in long queues, sometimes not really receiving the services of the quality of services that they need. And in case they still would like to receive the care and services they need, often they have to pay extra from their own pocket, since there is no comprehensive healthcare insurance policy like here, for instance, in the Netherlands. And unfortunately, bribery and corruption is still often case. So that's if you want to get the service in the healthcare, public healthcare. Otherwise, of course, the private clinics provide a better range of services, but they're also much more costly. So when we speak about our key population, in this case, sex workers, the costs and this kind of divided bit crooked system really does make does become a barrier for many sex workers in accessing SRH services regularly. So in the latest research, we also saw that the female sex workers do ask for care and treatment quite irregularly. So only if it's really, really necessary, if the situation is really bad. Of course, not everyone, but that's really a percentage that shows up in the latest survey. Whereas the attendance to HIV STI services is much more regular, mainly because they are more accessible, very often free, and also because they are often more targeted towards sex work clients. So when we look at the left column and HIV STI services providers, right? On the top row, there is an NGO site, and there's indeed the top preferred supplier or provider for the sex workers. Why? Because most of the times at NGO sites, they could also meet the peer counselors, so also former or current sex workers who could really tailor to the needs of the client. And NGO sites could be often mobile, so also meeting the need of sex workers to be mobile as well. But then unfortunately, that's the HIV STI testing and consultation. That's where the package of the services mainly ends, and at those sites. And since neither NGO sites nor tuberculosis sites or opium substitution therapy sites cannot really provide for the comprehensive diagnosis and treatment of some of the STIs that were tested positively. And for instance, what is a big problem in Ukraine that came out of the survey is that hepatitis C is quite on the rise as well, and apparently is quite problematic also to get treatment for. Once again, coming back to the shortages in the public healthcare system. So that's now kind of to outline the landscape of what's happening in healthcare, what's happening in NGOs. So how do they meet with each other? Yeah, how do the services marry essentially, if they do in Ukraine? And what happens is often sex worker clients who come to get regular testing on HIV STIs get also assistance from social workers, peer counselors, to also access further the healthcare services, treatment and care that they would need, for instance, for hepatitis C or some other essential needs, since often it's just, since the system is a little bit complex and crooked, it's not even clear where best to enter and where, in terms of costs, it's easier to get the services and treatment they need. AIDS centers also kind of in a way of exception, island of exception in the country, because their clients can actually access also broader SRH services, but it's mainly then tailored to HIV positive clients. So it's only very specific group then. And that's I would say where the intersection for now stops. And this leads me as well to further pinpoint the barriers. Some of them I already mentioned, and some not, but they're also essential to give a bigger picture of it all. So, and to summarize, so while HIV STI service providers such as NGOs and other sites are well tailored to the needs of sex workers, they speak their language. They also provide some more of holistical support, so it's kind of so-called comprehensive package, where what I mean by that is also psychological support, legal support, peer counseling. Unfortunately, they are short on actually providing further broader SRH services such as family planning or really further treatment of some diseases. But when it comes to healthcare services, like the biggest barriers become essentially the costs and the lack of necessary services. And the other biggest barrier mentioned is still, unfortunately, stigma and discrimination, either experienced in the past encounters with the healthcare providers or in the most recent ones. And that's also results later on in the general lack of trust towards healthcare providers. So then, the client just doesn't go to the healthcare providers anymore, or tries to avoid as much as possible. But then looking at enablers, they are basically mirroring, right, the barriers. And unless we can really find a way to integrate, to marry services as soon as possible with each other, what could be done at least is to enhance and to improve the two camps of services that are there. And looking once again at the HIV STI providers, service providers, it is essential to keep them funded, and that's also now kind of a looming uncertainty in the country since Global Fund started already transitioning out, and the next 5 years is planning to phase out completely. So that already reflects on the amount and quality of services that NGOs are providing. So there's big risk that this kind of comprehensive package for sex workers will shrink more and more. And the essential link that it provides, so like social work support and peer counseling that actually helps many sex workers to reach further to treatment, might also phase out and quite disappear, or will be also much less accessible. So that's important to really keep that support system going. Whereas looking at the traditional healthcare providers, it is indeed important, as also what Muna was saying, to continue sensitizing healthcare providers on the sex work needs, on the sex work friendly language as well, on the also on the very particular packages sometimes that the client comes with. So it could not be only STI, HIV infection. It's very often coupled also with tuberculosis, with the drug use, with other addictions, and not and very few health workers seem to be could be know how to work comprehensively with all that. And of course, further working on increasing accessibility of the healthcare services in the country in general. And last but not least, it's also underlined in the list of enablers, is the decriminalization of sex work. So coming back to the holistic approach, that's the factor that's really underlying barrier to all those barriers that are on the surface in the end. And it also consistently comes back in the surveys and research that criminalization leads to more violence, to more stigmatization, and also crucial to self-stigmatization of sex workers, which also prevents them from going and accessing services and care that they need.
Anna, you have 2 more minutes.
Perfect. I'm rounding up. So going back to the next slide, that's essentially what I already mentioned, the main needs and recommendations that also popped out from the latest survey, that the sex workers would definitely prefer to have integrated services and available all in one place. But until it's not possible, then a further improvement of the available healthcare services is necessary, as well as the support and reinforcement of HIV STI services is also necessary. And at the next slide, I would still like to give one more time a shout out to our partner in Ukraine, Legal Life Ukraine, and have just a small few details about the research, the survey I based my presentation on. So thank you to them for the work they are doing. And thank to all of you for being here and for your attention.
Thank you so much, Anna. I think the Ukraine is actually a fascinating case study, and again, you sort of like took us one step further than just looking narrowly at integrating services. You also looked at essentially the healthcare system in the Ukraine, where, like, as a country that is not a low-income country, but like a middle-income country, is moving ahead with universal health coverage, is actually transitioning out of global fund support, which has an impact on the services where they are being delivered, because they used to be delivered only by NGOs, but now it's going to move to the public sector. And there is obviously also the private sector, and how that actually creates a very complex network of services that sex workers need to navigate, and they're facing barriers already in each of those services. So that's fascinating to hear. Just for the benefit of time, I've just decided that we're not going to go into breakout rooms, but I'm just going to check with Hannah whether the Mentimeter is actually working. Yeah, it's at a thumbs up. Okay, great, that's good. But I do want to give time for those of you who have a question for either Muna or for Anna about the work that Mainline and Aidsfonds are doing. I don't see any hands coming up. But you have their addresses, and I'm sure that once you have, everybody will get the PowerPoint presentations as well. And I really all encourage you to actually have a proper look, because it's so rich in information, and I'm sure it will actually create some more questions about how you actually do it at field level. We were going to have a breakout room, but for the benefit of time, we're not going to do that. But what we wanted to do in the breakout room is actually sort of like on the basis of the sort of the high level evidence and guidance you all have been hearing from the WHO partners, and sort of the grassroots realities that you've been hearing from our NGO partners. I mean, all of us are in one way or another struggling with how we actually provide integrated services to the people that we are concerned about. And whether you're starting from an HIV background, or whether you're starting from an SRH background, or whatever a service background, you always find that you need to integrate more services. So the question was really going to be, how in our work are we going to sort of make sure that we are working towards integration? And because we don't go into the breakout rooms, I will just put up the Mentimeter straight away.
Maybe, Paul, before we do that, I see there's Marja who would like to ask a question, and also Annette has found the hands up button. Cool. So maybe we can take them first.
Okay, Marja, first. I didn't see you. Apologies.
Well, I couldn't find the hand button. It seems to disappear now and then. But anyway, so thanks for the presentations, and it's really interesting to hear really from the field what well, what the experiences are of the different key pops and how we can ensure that all the services or all the needs are being met at the same time. At the same time, you know, it may sound a bit strange, but it seems so obvious that if you are a sex worker and you are in need of family planning, that you probably also deal with some health issues, whether it's STIs or mental issues or whatever. And so I would like to ask, can you give us a bit more background on what the hurdles are? So why is it not yet common practice that some of these services are integrated? Has it to do with financial streams? Has it to do with capacity of the health worker force? So I haven't seen that very clearly in the presentations yet. So any information on the potential practical hurdles, that would be very welcome to me.
I'll give that question to either Muna or Anna first. Anna, I see you have your hand up. Go ahead.
Perhaps I could give a first try. Thank you for the question, Marja. Indeed, I would say one of the barriers in accessing the whole package of services, right? Also meeting, for instance, psychological support needs is sometimes indeed a lack of knowledge and of how to work with sex workers from the, I would say, regular health care providers, and also lots of still often cases of stigma and discrimination that, you know, it would also just be a barrier in talking openly, in providing really comprehensive help and care that sex workers would need. I think that's why essentially there is still a lot of division between NGOs providing services, right, and healthcare providers. And I don't say that it's in all countries, and we see also like promising examples in some of the countries where also NGOs are trying to get more collaboration and also successful collaboration with healthcare providers, and run programs where, for instance, it will be the other way around. Clients who come for SRH services, sex worker clients, could also then be incentivized to go further to NGOs and get tested for HIV STI. So it's really case by case situation. But like some of the barriers you already named or guessed are definitely right. Yeah.
Okay, Muna and Virginia also want to respond. And I understand that Annette actually had the same question. So we're covering that in one go. Muna first and then Virginia.
Good. I think a lot is already mentioned during the presentation, but also as Anna just said. But there's also one thing that funding is definitely important in this. We were lucky enough to have that flexibility of Bridging the Gaps funding, which allowed us to look beyond the regular harm reduction services, which we were able to look into what specific needs there are. When we're talking about mental health, we're talking about SRHR. So we were able to incorporate that into the programs we are running with our partners in country because of the flexibility of the funding. Secondly would be, there are structures within a country. For example, our partner in Mombasa didn't have that licensing where they were able to provide these services in-house. And thus they were forced to refer their clients to public health services, where again the stigma and discrimination would play a part in not be able for these women to access the service itself. So there's a lot of things that come into play, but the majority would be the flexibility of funding would play a big role. With that flexibility, we were able to support our partners to get that licensing and get the services in-house, expand to whatever other needs there are, including nutritional support, hygiene kits, sanitary pads, for God's sake, basic stuff. We were able to do that. And once you're able to do that, then you can cover a lot and bring in that holistic approach in it. And that makes it human instead of a target on an HIV statistic. So that's it.
That's very well said, Muna. Virginia, you have the floor. You had a thought on this.
Yeah, I'm very dark, sorry. I agree with what Anna and Muna have said, but I sometimes think it's almost like some people cannot conceive that a sex worker would ever also be a mother, or there's some kind of separation between these two populations. There are women of reproductive age who are having a lot of sex, but somehow in the family planning world, people don't see them as I don't know how to explain it. It's almost like family planning is quite wholesome somehow, and sex work is not wholesome. So they don't see the two coming together, if that makes any sense. I've just been struck by that over the last year when we went to this guidelines development group, which was with, and we invited people from sex worker community to come, and they, you know, I just don't think that they had thought about the fact that these were women who really needed this service. It hadn't occurred to them. Yeah.
Great, thank you, Virginia, for that perspective as well. Anna, I see Anna has her finger up. Anna, the last.
Yeah, it's just basically to continue on what Virginia just said, because even this morning I was talking to my colleague who was working on the new partnership we're going to start next year, and that's apparently this voice from sex workers was quite prominent in the building of the new partnership, that they are also quite tired of bearing just one identity of sex worker and not being seen as more than that, which, yeah, exactly what Virginia just mentioned, but also back up once again with the recent data from our experience from the field. It's really true.
Okay, great. I see that Annette still has her hand up. So Annette, you have a different question.
No, I just wanted to say the financial and political reasons behind this. For example, when you talk about PMTCT, prevention of mother-to-child transmission of HIV, at the global level, there was a request from member states to develop a tool for women who use drugs and for women in prisons. And we made the case, well, we can't just talk about PMTCT for HIV. We are talking about triple elimination: HIV, hepatitis B, and syphilis. That's what we're aiming for. But because of the funding stream and because the agency that was tasked to do this were HIV focused, it was really difficult to get this to be done and to introduce mother-child health, family planning, etc. So yeah, it's structural barriers, I would say.
That's a particularly interesting structural barrier. Sort of the sort of the compartmentalization, not just of services, but also of funding streams and UN agencies and technical agencies, etc., etc. That might be a topic for a next expert meeting. But for now, I want to ask Hannah to put up the Mentimeter. If we're using the same system again, our question to you is, on the basis of what we've been discussing today, what would be the next step that you yourself or your organization could take to actually work towards more holistic services? And here we go. It's coming up on the screen. So you go to menti.com on your iPhone. You type in the number. Oh, you've already done that. And then you can just answer the question. Okay, I've submitted mine. Yeah, it's coming up. Yeah, work on universal health coverage. That's a very good one. I was just thinking that. And to fund integrated approaches only. Yeah, I mean, make sure that the funding is not further dividing stuff. Promote universal health coverage and people-centered care within that. Continue to advocate. Yeah, I mean, the person working from the advocacy point of view, advocate for holistic services. Better integration of SRHR and a holistic approach. Again, universal health coverage. Maybe we should actually have a community of practice. We have a community of practice on universal health coverage. Maybe we should do that within ShareNet. I think it's a fascinating. Allow flexibility of funding and apply a human needs-based approach. Yeah, obviously. increase advocacy with governments, better integration. There's 10 people who submitted. I thought we had more than 10 people in the room. In any case, that's great. It's nice. It's always nice to see. Keep thinking about integration and base interventions on eliminating the root causes. Yes, going back to the root causes. And some of the root causes probably are also the structural factors that we have been talking about, like stigma and discrimination, lack of empowerment, allow flexibility of funding and apply. Yeah, we've had that, increased advocacy. Great, those are great ideas. And I'm glad that people actually have been feeling encouraged to sort of take the next step. Hannah, can we have the wrap-up slide?
Just to clarify, what is the wrap-up slide?
My slides.
Ah, thank you.
Okay, so in preparing for and talking with all the presenters about and the community of practice colleagues about what we were talking about, I was struck that, you know, there is also some confusion about terminology, and particularly linkages and integration are sort of used as the same thing. And I went back to what the WHO and other technical agencies have been saying. And for me, it was quite useful to understand that when we're talking about linkages, we're talking about something much bigger than integration. It's a bidirectional synergies in the policies, the systems, and the services between SRHR and HIV. And it refers to the broader human rights-based approach that we've been talking about, of which service integration is only a subset. And integration refers to the service delivery level, and it really can be understood as joining operational programs to ensure effective outcomes through many modalities. For example, multitask providers, referrals, one-stop shop services, everything under one roof, etc. So integration is really a subset of a much bigger thing like linkages. Hannah, can I have the next slide? So, and how it hangs together, I thought that this was actually a very nice way of presenting it, where you see sort of in the middle, those two purple pink balls are the SRH services and the HIV services. And you could come up with the harm reduction. You could come up with all the other services that really, we want to make sure that there is as much as possible overlap so that people have one place to go to and only one barrier to overcome. But we have to see this within an environment which is much bigger, and that is what the linkages are about. And it's not just the health systems. And that's, you know, the health systems that Anna was talking about in the Ukraine, how the health system is basically organized in such a way that it doesn't favor integrated services is one thing. And I think Muna also made very clear that the sort of beyond the health services, you have an enabling environment. You have an environment of disempowerment, stigma, and discrimination that also has an impact on the health systems that doesn't allow for integrated services. Hannah, the next slide. And then finally, well, why are we actually trying to get those integrated services? You know, and this is basically how it works. So look, if you go all the way to the left, that if you actually have a more enabling environment to link SRHR and HIV responses, and if you have a stronger health system that supports that integration, and at the bottom, if you actually have one-stop shops or good service linkages and referral systems, you do actually get at the right side, at the outcome level, reduced stigma and discrimination, increased access, increased use, increased quality, reduced gender-based violence, and improved program efficiency and value for money. And then obviously, if you get all that, what we want is that we have an improved health and human rights situation for the people that we're concerned about. So this, for me, I will give this slide as well, is a really nice way of how the WHO and UNFPA and UNAIDS have been writing about this in the past. So we don't have to reinvent the wheel. That said, I would really like to hand over to Marja, who has been honoring us with her presence today. And as you are actually, in a way, you're the mother of all our programs. You're supporting the WHO, you're supporting this research, you're supporting ShareNet. and we're all very grateful for the support that we're getting from the ministry. So Marja, I'd really like to invite you to come up with some last observations.
Yes, thank you, Paul. And please do not overestimate money. I mean, I'm just working at the ministry that happens to have money, and that makes me makes my position quite attractive in a way. But I think nothing could be done without the people who are really working on the ground and working with the different target groups. So I'm really happy that I was able to attend this meeting and hear from the people who know best. And that helps us again to help strengthen our policy and to indeed make sure that we are not funding separate initiatives. And I know that, for instance, the Bridging the Gaps program, I was also the contact person within the Ministry of Foreign Affairs for Bridging the Gaps. And I think one of the bigger charms of this program was indeed the integration of service delivery and rights, a rights-based approach. And this is still within our own ministry a constant struggle where people feel like, okay, we need to focus on the rights-based approach. Service delivery can be done by others. Which is not always the case, particularly if you talk about marginalized groups. And I think we have seen some very great examples from Kenya and from Ukraine today, where the government has stepped in. And for us, that's really a big success. But we are also aware that this is not possible in every country. And there is a continuous need also for service delivery. And well, I have seen with my own eyes that even though Bridging the Gaps was set up as a program to fight HIV/AIDS, that, you know, people are not black and white. It's not that you either have HIV/AIDS and or you don't have HIV/AIDS and then you don't have any problem. I mean, sex workers in Vietnam, maybe their HIV status is decreasing dramatically, which is good news. But the other issues they were confronted with is quite sobering. And I think, you know, people from Mainline know exactly the same is happening in relation to drug use. And maybe intravenous drug use is reducing or going down the numbers, but other ways of drug use or substance abuse may also create other forms of health risks. And so this integrated approach is really important. And even for us, it's still not always working well in practice. We advocate for integration in our multilateral approaches through UNAIDS, through the Global Fund, through WHO. I mean, we don't have to tell much to WHO, of course, Annette, because you are such an expert there. But yeah, it's sometimes also difficult because all donors have their different flavors of the day. I mean, we know about USAID. I mean, they are one of the biggest donors of HIV/AIDS programming worldwide, and we are really appreciative of that. But we also know that their way of programming has some limitations. And so we have to remain flexible. We also have to, well, remain open and listen to each other and listen to what the real needs are on the ground. And sometimes we also need to be a bit, well, how do you say that? I don't know the exact word, but, you know, there comes a time where we as a government also have to stand up and say to other governments, listen, 62% of all new HIV/AIDS infections can be found in key populations. So why do you still say that these groups do not exist, or why are you not addressing the needs of these groups? And so I'm always struggling to what, how do you say that? Where does our responsibility end as a donor? And where does the responsibility of a government, of a national government start? And what can we do also from a diplomatic point of view to bring some future or some sustainability vision into our diplomatic debate as well. So that is also what we are doing, and what we are doing more and more. We have again strengthened our diplomatic team within the Ministry of Foreign Affairs. And I think it's indeed this multi approach, funding projects, funding multilateral organizations, but also engaging in a very pertinent diplomatic dialogue with governments, that we can bring this further. And then I forget the fourth, which I really wanted to mention, that is investment in innovation. And I think although this is something that we do not talk a lot about, the government of the Netherlands is also investing in product development partnerships, for instance, in the development of the vaginal ring that IPM is working on for the prevention of HIV/AIDS, and it would be such a great improvement if we could combine this HIV/AIDS prevention tool with contraceptives, so that we have one tool that has a dual purpose. And I think this is something that we dream of, we'd like to continue to work on. And so this is just a quick snapshot of what we are doing, but we are not there yet. And again, we are strengthened by today's discussion that we need to continue to work on an integrated approach, and that there's still opportunities to improve and to do things better. So thank you very much.
Thank you so much, Marja. And I'm aware that we are 10 minutes over time, so I'm going to, without much ado, I'm going to thank everybody. I'm going to thank specifically Nienke and Annette for helping to conceptualize this expert meeting that we're having today. I'm going to specifically ask everybody's thank for the speakers, Virginia, Michelle, Muna, and Anna. It's been a real great pleasure to work with you in preparing this. Shout out to Hannah from the Secretariat for helping to organize this. And most of all, everybody who joined today. And I just want to, before we close, I just want to say, everybody who is not yet a member of ShareNet Netherlands, by all means, join us, because we're the knowledge platform that organizes these kinds of things. And we just started a new community of practice on sex work. So everybody who is particularly interested in sex work, please join. On that note, thank you all very much and have a wonderful evening. Until the next time.
Thank you, Paul.
Thanks, Paul.
And everybody.
Bye.
Bye-bye.
Bye.
Thank you all. Bye-bye.
Thank you. Bye.